Dr. Miller, tell me, with health coming up, what is one critical and pressing issue that's facing healthcare right now?
I think, again, there's really three areas that are simultaneously revolutionizing our approach here. And it's not like sci-fi, it's really actually happening right now. So let's talk about each one. The first one is FHIR and CDS hooks. FHIR is basically the part where patient information flows out of the electronic health record, and CDS hooks is where recommendations about what to do flow back in. FDB, this was kind of like a fantasy in a lot of ways until recently, but now it's happening. And FDB is one of the first companies to use this interoperability messaging standard to actually scale our patient-specific decision support across sites. One of these products that, just as an example, that we've got is called Targeted Med Warnings. And it does some really cool stuff. Like, for instance, we have this QT prolongation sudden death decision support tool that only shows alerts that a medicine could cause a heart problem to patients who actually are at high risk because their EKG showed that they were at high risk. This type of tool would have taken months to build at each site where we deploy it, but instead we build it once and everybody gets to use it because we can use FHIR to pull the heart rhythm data out and CDS hooks to squirt our recommendation back in front of the provider or the pharmacist without having to build it locally. So this allows us to put out this tool at a fraction of the cost it would take a site to make it, and then take all the pooled resources and develop new use cases all the time. And this is happening across the whole industry. So the second big innovation is sort of what I'm calling common data models, but it's basically taking all the info that can be pulled out of the EHR in standardized fashion using FHIR and then aggregate it across sites to become what pharma companies and the medical literature call real-world data. I did a lot of work in this area on a big common data model called OMOP with this program called Odyssey while I was at Hopkins. And now I'm taking sort of this standard approach to evaluate the effectiveness of, as an example, our targeted med warning tools across sites. I'm starting with a problem called hyperkalemia, which is high level of potassium in the blood. We're now evaluating the real-world clinical impact of our tools, not just trying to get doctors to see less alerts, but to actually see how often are patients in less danger, how often are patients' lives actually improved by this stuff. And then we take that and we further improve the tool. And again, this is an example, but this is happening across the whole field, and we're coming up with these standardized approaches. And then the last area is AI, large language models, what we're all obsessed with. These are having really broad impacts in all of medicine, though I think most especially for their ability to do what was previously an extremely labor-intensive process, natural language processing, which was pulling usable data out of free text notes or papers or FDA publications or whatever. AI is already starting to change and allow us to much more rapidly cycle through information to provide really good quality recommendation. So the takeaway is not just we're at the edge of a massive change, but we're actually mid-change.